Hi guys, so for today's video, we are gonna talk about the examination of the musculoskeletal system. It's gonna be quite extensive, so I want to divide the examination into like 2 or 3 different parts. So for this video, I want to specifically talk about the examination of the mandible, the shoulders, the elbow, the hands, and the wrists. The rest I'll probably do in a separate video or maybe divide them into 2 separate videos. So for today, let's first discuss some of the tips and general considerations when we are examining the musculoskeletal system. So firstly, our examination has to be systematic. So we can't just examine the shoulder and then jump onto the knee and then back on the shoulder and the elbow. It has to have a flow, and it has to have like a logical sequence to this, okay? So typically we start from like the head to the toe. Second thing is we need to inspect and palpate not just the bones, but the joints and the surrounding soft tissues around that joint. We also have to assess the patient's range of motion. So we test both the active and the passive range of motion. So recall that active range of motion is basically the patient moving the joint by their own efforts, and passive is when a doctor or a machine helps the patient move that joint. Okay, so those are very important distinctions. And then we also have to be able to perform some special maneuvers to test specific movements. And if the joint is injured, maybe consider getting like a scan, like an x-ray first before attempting any kind of movement, because that just might induce more pain to the patient and might do more damage. During inspection, we typically look for the symmetry, alignment, any bony deformities, and any indications of like inflammation. So swelling, redness, pain, and warmth in the area. And then in terms of like symmetry of involvement, if there's only one joint involved, then we typically that's due to trauma. And for instance, in rheumatoid arthritis, the complaint would be polyarticular pain. So that means involvement of 4 or more joints. And the pain would be symmetrical. So the pain felt on the joints on the left side of the body is also felt on the joints on the right side of the body. We use palpation to assess the surrounding tissues, like the muscles, any subcutaneous nodules, any skin changes, and we also note any crepitus. So crepitus are just like an audible or a palpable, like crunching sensation or sound during the movement. We also have to test the range of motion and perform some special maneuvers prescribed for each joint, just to assess any limitations in the range of motion or any joint instability or excess mobility. So let's first talk about the mandible. So specifically we assess for the temporal mandibular joint, or the TMJ. So this is actually the most active joint in the body, because if you think about it, we open and close our mandible so many times during the day. I think it's about up to 2,000 times during the day. So in terms of the type of joint, it's a condylar or a condyloid synovial joint. If you don't know what that means, please watch the previous video. So basically, the TMJ is the articulation between the condyle of the mandible and the temporal bone. And there's actually like a fibrocartilaginous disc that cushions the action of the condyle of the mandible against that capsule in the articulating surface of the temporal bone. So when examining the temporomandibular joint, or TMJ, we start again with inspection. We inspect the face for symmetry. We note any swelling or redness that we can identify by inspection. And then we palpate. So what we do with palpation is we use the fingertips of our index finger. We put the tips of our index finger in front of the tragus of the ear on both sides, and we ask the patient to open and close their mouth. And when they open their mouth, our fingertips should fall into that joint space. So when you're assessing, so when you finally locate that depression, that joint space, you assess for things like the smoothness of the motion of that joint, any swelling, any tenderness, and any crepitus. And then we palpate for muscles of mastication. So we have the temporal muscle, the pterygoid muscle, and the masseters, okay? And then after that, we need to assess the range of motion. So the motion of the TMJ is threefold. So we assess the opening and closing. So it's just like this. Protrusion and retraction. And the side-to-side or lateral movement of the TMJ. So it looks so silly doing these. So that's for the range of motion. Moving on to the shoulders. So let's first review some basic anatomy of the shoulders. So three different bones actually articulate in the shoulders. We have the humerus, the clavicle, and the scapula. And we have three joints that articulate in the shoulder. So we have the glenohumeral joint, where the humerus articulates with the glenoid fossa in the scapula. We have the sternoclavicular joint, where the medial end of the clavicle articulates with the upper end of the sternum. And then we have the acromioclavicular joint, where the lateral end of the clavicle articulates with the acromion process of the scapula. There are also three muscle groups that attach at the shoulder. So the first group of muscles include the scapulohumeral group. So the scapulohumeral group, they rotate the shoulders laterally. So these include the sits muscles of the rotator cuff. So sits muscles of the rotator cuff include the supraspinatus, infraspinatus, the teres minor, and the subscapularis, okay? So those are the four rotator cuff muscles of the scapulohumeral group. And then the second group of muscles that attach at the shoulder is the axioscapular group. So the axioscapular group, what they do is they pull the shoulders posteriorly, okay? So the muscles in this group include the rhomboids, the traps, the serratus anterior, and the levator scapulae. And the third group of muscles, we have the axiohumeral group. So the axiohumeral group, they rotate the shoulders internally, okay? So these muscles include the pectoralis major, the pectoralis minor, and the latissimus dorsi. So when examining the shoulders, again, we start with inspection. We inspect the shoulders and the shoulder girdle anteriorly, and posteriorly, we inspect the scapula and the related muscles. And then we move on to palpation. So we palpate the sternoclavicular joint, and then we just kind of trace the clavicle with our fingers laterally and upwards until we reach the acromion, or the summit of the shoulder. And then posteriorly, I'm not going to be able to show you properly, we just trilocate the bony spine of the scapula, and we just palpate that, tracing it, following it upwards and laterally until we get to the acromioclavicular joint. And then from the acromioclavicular joint, we just trace it down medially and downwards until we palpate the coracoid process. Okay, so again, start at the sternoclavicular joint, palpate for tenderness, swelling, and things like that. Trace the clavicle laterally and upwards until you reach the acromion. And then at the back, trace the bony spine of the scapula laterally and upwards until you reach the acromion again, and palpate for the acromioclavicular joint, and then medially and downwards to the coracoid process. And then we palpate the greater tubercle, where the sits muscles of the rotator cuff insert. And then we palpate the biceps tendon in the intertubercular groove. And then we lift the humerus posteriorly. So we help the patient lift the humerus posteriorly. And we try palpate for the subacromial and the subdeltoid bursa. feel for any tenderness. And then what we do is we assess the range of motion by asking the patient to perform the 6 different types of motions that the shoulder, that a normal shoulder should be able to do. So firstly, we have flexion and extension. So I'm just gonna demo. It's easier that way. So flexion of the shoulder is basically just ask the patient to raise their arm forwards and overhead. So I do have problems with my shoulders, so you're just gonna hear my shoulders click a lot, and I probably won't be able to perform all of these movements. Right, so 6 motions of the shoulder. Okay, let's start with extension and flexion. So this is flexion, so lifting the shoulder, well, the arm forwards and overhead. That's flexion. Extension is lifting the shoulder or the arm backwards, right? That's extension. And then we have internal rotation and external rotation. So internal rotation is asking the patient to do this. Yeah, so just putting the hand behind and touching the scapula on the other side, right? And external rotation is lifting the arm to the side, bending the elbow, and rotating the forearm to the ceiling. That's external rotation, right? Again, internal rotation and external rotation. And then we have abduction and adduction. Abduction is lifting the arm to the side and overhead. Okay? Adduction is crossing the arm over in front of the body. Okay. Right. So abduction again, lifting the arm to the side and overhead. And adduction is crossing it over the body. So now what I'm going to demo are some of the special maneuvers that we can use or we can do to assess the shoulder function of the patient. So the first one is called the crossover test. So this is a passive range of motion test. So we help the patient adduct the hand across the body, okay? So this is the crossover test. And this is a test for the acromioclavicular joint. So the positive sign would be pain during the adduction of the arm. So that suggests that there are problems in the acromioclavicular joint. The second test is just to test the general shoulder rotation. So this is called the Aptly scratch test. Right, so the Aptly scratch test is just this. So you're just trying to reach the scapula on the other side from below and from above, okay? And then we have numerous tests, actually, special maneuvers to test for rotator cuff problems. So the first one is just called I think it's just the painful arc test. So you just ask the patient to abduct the arm from is it 0 degrees to 180? So 0 degrees to 180, okay? And the positive would be pain between 60 to 120 degrees. So if there's pain between 60 to 120 degrees when the patient abducts the arm from 0 to 180 degrees, then that suggests that there is some subacromial impingement, okay? So the second test for rotator cuff is the near impingement test. So I can't do this to myself because this involves the doctor kind of pressing against the scapula while the doctor, with one hand, while with the other hand raises the arm of the patient forwards and overhead, but I can't do that to myself. So let's just imagine there's a doctor behind me pressing against my scapula, and with one hand and with the other hand passively flexing or raising my arm forwards and behind, well, overhead, okay, above, okay? So again, pain there suggests some problems with the rotator cuff. The third special test for the rotator cuff is called the Hawkins Impingement Test or Impingement Sign. So I probably won't be able to do this with my right shoulder because I have a problem with my right shoulder. So I'll demo this with my left shoulder and my left arm. So what you ask the patient to do is to flex the shoulder and the elbow at 90 degrees. Yeah. So like this. And then with you support their elbow. So the hand should be faced, so the palm should be facing down, okay? And then you just, with support this elbow, try internally rotate the shoulder. Okay, so just to demo again, Hawkins impingement sign. Flex the elbow and the shoulder at 90 degrees, the palm facing down, and then with your hand on the forearm close to the elbow, you just try internally rotate the shoulder. So with my right, it's actually gonna hurt. So even just doing this, just pressing on that hurts. Okay, so that is the Hawkins impingement sign. Positive would be pain during the test. And again, that indicates some problems with the rotator cuff. So the fourth test we can do for rotator cuff is called the empty can test. So to do the empty can test, you ask the patient to lift their arms forward, right? And internally rotate their shoulders with thumbs pointing down. So just tell them, imagine you're emptying out a can. That's why it's called the empty can test. So lift your arms forward as if you're emptying a can, which internally rotates their shoulder. Yeah, make sure the thumbs are pointing down. And the doctor would place a downward pressure. So the doctor will push down on this arm and obviously the other one and instruct the patient to resist that downward force, okay? So pain in this one indicates problems with the supraspinatus muscle. To test for the function of the infraspinatus muscle, we just do the external rotation resistance test, I think. I don't think it has a specific name. So what you do is you ask the patient to flex the elbow and the arm and thumbs pointing up, and you place your hand against their hand and you ask them to push out against your hand, okay? So they're basically doing this and you're pushing in as they're pushing out. So they're pushing out against your pushing in like force, okay? So it's like that. So this is again a test for the infraspinatus muscle. And then the last test for the rotator cuff is the, I think, drop arm test. I think it's called, I don't know what it's called. So basically what you ask the patient to do is to abduct the hand, the shoulder, up to 90 degrees, so shoulder level, and instruct them to like lower it down slowly. This actually hurts me a little bit because I have problems with my shoulder. Okay, so again, the drop arm test. Ask the patient to abduct their shoulder to 90 degrees and lower it slowly. So the positive test would be pain as they're lowering it down, and that suggests problems with the rotator cuff. So either a sprain, a partial tear, or a full tear. So these are all the special maneuvers for the shoulders, and now let's move on to the elbows. So with the elbow, let's first go over some of the basic anatomy again. So we have three bony structures in the elbow. So we have the humerus, the ulna, and the radius. So these are the bones. And we have three articulations in the elbow. So we have the humeral ulnar joint. So that that's the articulation between the humerus and the ulna. We have the radiohumeral joint, which is the articulation between the radius and the humerus. And we have the radioulnar joint, which is the articulation between the radius and the ulna. So when examining the elbow, again, we start with inspection. We just inspect the elbow for signs of swelling, any redness, any nodules, and then we move on to palpation. So we palpate, so we just slightly flex the patient's arm about 70 degrees. We palpate the medial and the lateral epicondyles of the humerus, noting for any tenderness. And then we palpate the olecranon process. Yeah. and then we palpate the extensor surfaces of the ulna as well, again noting for any tenderness. So if there is tenderness and pain on palpation in the medial epicondyle, then that suggests medial epicondylitis or golfer's elbow. If there's any tenderness or pain in palpation of the lateral epicondyle, then that suggests lateral epicondylitis or tennis elbow. Also, we can palpate for the sensitive ulnar nerve. So we can palpate for this posteriorly. So it can be found between the medial epicondyle and the olecranon process. Also, we have to note any displacement of the olecranon process and the olecranon itself, especially if there is history of trauma or injury to the elbow. And after palpation, we assess the range of motion. So with the elbows, it's quite straightforward. So we ask the patient to demonstrate flexion and extension. So with flexion, it's just like flexing the elbow, so bringing it up like that. And extension is bringing it back down. So flexion and extension. And then we ask the patient to demonstrate supination and pronation. So ask the patient to flex the elbow and turn the palms up. So this is supination, and then with pronation, turn the palms down, so they're facing down. Okay, so now let's move on to the hands and the wrists. So let's first review the basic anatomy, starting with the bony structures in the hands and the wrists. So we have the distal radius, the distal ulna. We have 8 carpal bones in the wrists. We have 5 metacarpal bones. We have 5 proximal phalanges. We have 4 middle phalanges. And we have 5 distal phalanges. So it's only the thumb that lacks like a middle or an intermediate phalange. Okay, the rest, they have middle phalanges. And then in terms of articulations, so we have the radiocarpal joint, which is the articulation between the radius and the carpal bones. We have the radio-ulnar joint, so the articulation between the radius and the distal ulna. And then we have the intercarpal joints. So those are just the articulations between the carpal bones themselves. And then in the hands, we have the metacarpophalangeal joint, or MCP. I can never remember. I just call it MCP. So metacarpophalangeal joint, I think. And then so MCP, and then we have the PIP, so the proximal interphalangeal joint, and the and then it's probably better if I show you using my index finger. Okay, so the MCP, the PIP, and the DIP, the distal interphalangeal joint. Okay, MCP, PIP, proximal, DIP, distal. Okay, so those are the articulations in the wrists and in the hands. You have to be familiar with the structure of the carpal tunnel as well. So the carpal tunnel is just like a channel beneath the palmar surface of the wrist, so just around that. And this contains important structures like the median nerve. So when we're examining the hands and the wrists, we start with inspection. So we just inspect the hands in motion. So when the patient is using their hands to speak, for example, we just look at their hands in motion to see if the motions, the movements are natural. When the hands are relaxed, the fingers should be slightly flexed. And then we can inspect the hands and the wrist closely for any signs of redness, swelling, deformities, some abnormal nodules. We can also observe the palmar surface of the hand, especially the contours of the palm. So we have the thenar and the hypothenar eminences. So moving on to palpation, we palpate the distal ulna and the distal radius on the medial and lateral side of the wrists. And then after that, we palpate for the radial styloid bone and the anatomical snuff box just over here. So pain or tenderness in the anatomical snuff box suggests a scaphoid fracture, which is a common injury or a common problem. And then after that, we palpate the 8 carpal bones and the 5 metacarpals and the proximal, the middle, and the distal phalanges in every single digits, in every single finger. Okay, and then after that, we compress the MCP joint, so the joints here, from each side, checking for, again, pain, any tenderness, abnormal nodulations. And then we palpate the medial and lateral aspects of each PIP and DIP. So again, this is the PIP, the proximal interphalangeal joint, and the DIP, the distal interphalangeal joint. So for each digit, for each finger. So bony nodules on the PIP are called Bouchard's nodes. So these are commonly benign and quite often found in people with osteoarthritis. And bony nodules on the DIP, the distal interphalangeal joint, are called Heberden's nodes. And again, they are benign and commonly found as well in osteoarthritis. And then we have to assess the range of motion. So again, we have 4. We have extension, flexion, abduction, and adduction. So what you need to do is ask the patients to have their hands in front of them with palms facing down, and ask them to lift their fingers down or point their fingers down towards the floor. So this is flexion. And then point their fingers up to the ceiling. This is extension. And then for abduction and adduction, they're also called different things. So for adduction, this is adduction. It's basically pointing the fingers towards the midline. This is also called radial deviation. And then abduction is pointing the fingers away from the midline. So this is also called ulnar deviation. If there are any complaints of carpal tunnel syndrome, or if you suspect carpal tunnel syndrome, what you can do is to assess the sensation in the pulp of the index finger, which is innervated by the median nerve. You can also test the the sensation in the pulp of the pinky finger, which is innervated by the ulnar nerve, and at the dorsal aspect, at this like little web space between the index finger and the thumb, which is innervated by the radial nerve. So in carpal tunnel syndrome, it's common to have decreased sensation in the like areas of the hand that are innervated by the median nerve. So for instance, the pulp of the index finger. Also, you could test the patient's hand grip strength. So you can ask the patient to grasp your second and third fingers and squeeze as hard as they can. And if there is a decreased grip strength, then this may be a sign of carpal tunnel syndrome, but can also be a sign of other things like arthritis or de Quervain's tenosynovitis. Also, for de Quervain's tenosynovitis, we can use the Finkelstein test, I think. So the Finkelstein tests, you ask the patient to grasp their thumb against their palm like this, and then to kind of like, what do you call it, point it towards the midline. So they do like an ulnar deviation like this, okay? So grasp their thumb against their palm and then do ulnar deviation, or point their like hand towards the midline. And any pain here indicates, well, is indicative of de Quervain's tenosynovitis. For carpal tunnel syndrome, there are 3 specific maneuvers that we can do. So we can do the thumb abduction. So this is the patient's hand, this is the doctor's hand, And what the doctor has to do is ask the patient to lift the thumb straight up against that downward resistance. Again, pain is a positive sign for carpal tunnel syndrome. And then the second one is Tinel's sign. So that's just tapping the course of the median nerve and asking the patient if there's any pain in the second, third, or fourth fingers, which are innervated by the median nerve. The last one for carpal tunnel is the, what is this called? There's a name for it, Phalanx Sign. So Phalanx Sign is putting the backs of the hands against each other like this, and any tingling, numbness, or pain in the second, third, or fourth finger after within 60 seconds is again another positive sign for carpal tunnel syndrome. Finally, we can test the range of motion of the fingers. So for flexion, we ask the patient to make a tight fist with the thumb across the knuckles. So this is flexion, okay? And then extension is just spreading the fingers apart, so which is opening the hand. So flexion, extension. We can also test abduction and adduction. So abduction is just spreading the fingers, and adduction, putting them closer. Abduction, adduction, okay? So flexion, extension, abduction, adduction.